Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and we are going to be doing a series on men's health right now. Today, we're going to be doing real talk about prostate health. I've got Dr. Aye Lwin with me here. He is with Arizona Urology Specialists, and he's going to do a great overview for you on prostate health and what you need to know. Welcome, Dr. Lwin. How are you today?
Doing well. Thanks for having me.
Great. Let me go ahead. I'm going to put your PowerPoint up. If you're watching from home, please feel free to put any questions into the chat, and I will ask Dr. Lwin when we're all finished. You can go ahead and start, Dr. Lwin.
Awesome. So thank you. Thanks for having me. I give this talk about once every year, so if you've attended before, it may seem a little redundant. This talk is, as the slide says, benign prostatic hyperplasia, or BPH as it's most commonly known. If you've heard this talk, I apologize. It's going to be pretty similar. I think there's a few new slides in this presentation today. How do I advance to the next slide?
Okay, now it should go.
Okay, let me try that. Okay, so this is all just boring stuff about me and but here. So today we'll be talking about. So I'll introduce myself. I'm Aye Lwin. I'm one of the urologists here. I work at TMC. That's where I do most of my surgeries. The group I work for under right now is called Arizona Urology Specialists. So I think that my contact information is there if any of this sounds relevant to you. And yeah, please let me know if you can't hear me or anything like that. I'll definitely try to speak up. So today, what we'll be talking about is, the prostate. What is the prostate? What are the functions of the prostate? And then we'll talk specifically about BPH and how do we treat that. This is one of the most common diseases in men. And so it's really important that you guys have an understanding of what it is, what the signs and symptoms are to look for, and how to treat it if it really is affecting your life. So the prostate, what exactly is it? It's a walnut-sized gland at the base of the male bladder, and it surrounds the urethra. This is a nice picture of it here. Let's see if I can get this mouse pointer here. But this is the prostate right here, okay? Your bladder is here, and then this is your urethra. If you ever see me in clinic or anything like that, I always have a few analogies, but think of your prostate like a donut. And the prostatic urethra, this part right here, is the donut hole. And then the prostate is the dough of the donut, really. The bladder, it squeezes. And then think of that like a pump. It's all plumbing, right? And then it has to squeeze through that donut hole. So as you get older with BPH, that donut gets larger, that hole gets smaller, and then therefore, your bladder may have to work a little bit harder. Okay. And we'll be talking about the signs and symptoms of BPH as well a little bit. So the most common conditions that affect the prostate, there's about 3 of them. There's BPH, which we'll be talking about, or benign prostatic hyperplasia. Prostatitis, which is an infection of the prostate, and then prostate cancer, which is one of the most common cancers in men too. Okay. So an overview of BPH, like I was saying, benign prostatic hyperplasia, or BPH. Benign just means that it's not cancer. Prostatic means that it has to do with the prostate, and hyperplasia means that the amount of cellular matter in the prostate is increasing. Okay, so that's why it grows. Normal adult size, I like to think of it like, it's the size of like a walnut. I think that's, something that we can relate our heads into. 1.5 inches diameter is kind of difficult to imagine sometimes. And then BPH can cause, cause something called bladder outlet obstruction. Bladder outlet obstruction is just the fact that bladder has to work harder. I like to think of it just as a blockage. And then that blockage can cause lower urinary tract symptoms, or LUTs. And those are the symptoms that you or someone may be experiencing. Okay.
What was that last? Lower what?
Lower urinary tract symptoms, or LUTs, right here. Okay. So relating BPH to cancer, I think a lot, I got a lot of questions even today in clinic about, hey, does my BPH cause cancer or anything like that? So I want to be very clear that BPH is not prostate cancer. It does not cause prostate cancer. The symptoms can be similar though, and that's why I have to, it's my job to tease that out between, is one prostate cancer, is one BPH, are they, because the symptoms are similar. And the important part is that it can coexist with prostate cancer too. So, oftentimes when I work up my patients for BPH, I'm also looking at prostate cancer and making sure I'm not missing anything else. And then prostate-specific antigen, or PSA, that's a blood test that's common for 55 and 50, patients 50 and older. It's a screening test for prostate cancer, probably one of the most common types of screening tests. And so those cannot distinguish BPH from prostate cancer, and therefore, that's my job to figure that out. So a normal versus enlarged prostate, so like I was saying, think of that prostate growing, that donut hole getting smaller, and therefore your bladder has to work harder. If that process happens over time, the bladder is a muscle, and that muscle can just get thicker over time. And our bladders are not designed to be thick, okay? Just like any other muscle in the body, if it's working overtime, like if you're doing a lot of, bicep curls in the gym, your biceps are gonna get bigger, right? Same thing with your bladder. Your bladder will get thicker the more it has to work to expel that urine out. Unfortunately, our bladders are not designed to do that, so it may not function as well. And that's when we can get some of those lower urinary tract symptoms from BPH. I think this is also another important point here, that prostate size does not necessarily always correlate with obstruction or the degree of symptoms. And what that means is basically, I have a few patients, their prostates are 5 to 6 times the size of a normal prostate. And I ask them, hey, how you being? And they'll tell me just fine. And I do my tests and they do great. And I leave them alone, okay? So not just having a big prostate doesn't always necessarily mean that you'll have symptoms. And on the other side of that, on that spectrum, I have patients that, their prostate is a normal size and they're having really bad symptoms. And sometimes when I take a look inside, it's because it may not be so big, but right here, it's a nice straight line for the urine to come out. But if there's a kink or something in that prostate, it may be acting like a big prostate, and it'll be difficult for the urine to be expelled out of there. So those are some considerations that when I'm looking at the anatomy of the prostate, I'm assessing for to make sure that there isn't a whole lot of obstruction from the prostatic urethra. So going back to those lower urinary tract symptoms, or the symptoms of BPH, I like to think of it in terms of two different sets of symptoms. And so one of them is a blockage problem, okay? So the blockage problem is going to be something like a weak stream. Think of it in terms of plumbing again, right? If your pipe is really small or it's blocked, your stream is not going to be so great. You're not going to be able to empty your bladder. You're going to have to really push to get the urine out. That urine may, may start and stop. You may have some dribbling. The other problem is that bladder problem, or it could be a combination of both. But that set of problems is like a storage problem, meaning that when that bladder gets really thick and gets irritable, and you may notice that you go to the bathroom a lot, and you may have urgency when you have to go, because the bladder, like I said, is not designed to be so thick. The other thing is if you don't empty your bladder, you may also go frequently to the bathroom, because you're not emptying your bladder completely. So if you think of your bladder like a gas tank, you'll be going from full to half full, full to half full. So that means more trips to the gas station, right? Or in this case, the bathroom. So, there's a lot. And then I guess one thing on here that wasn't on there was, it could also help you, or it also can make my patients go more at night too. And that's another common problem I have as well. So This is very common in men, as I was saying earlier. About 95% of patients, they have some sort of symptoms they're not happy with. They don't want to spend the rest of their lives with these symptoms either. About half of patients, 51 and 49%, 51% say that it interferes with some sort of aspect of their life. And then another 49% say that they have sexual problems as well due to the lower urinary tract symptoms. Obviously, it can affect not only your routine, but if you're out with your spouse or your partner and you're out on a date or whatever at the restaurant and you're going to the bathroom every 30 minutes, that may kind of ruin that date or your time with your partner. So it also can affect the people in our lives. So who gets BPH? So basically, this is a problem of time, in my opinion. Unfortunately, that prostate starts growing. Generally speaking, in your 50s. So by age 60, 50% of men have this issue. By 85, about 90% of men have this issue. In terms of risk factors, what can cause BPH? The only links that they really have are just BMI, so a higher body mass index, and related to that is if you're not exercising, you probably will have a higher BMI and therefore an increased risk of BPH. So how is a enlarged prostate diagnosed? I'll tell you what I do, as well as what some other urologists do. I'm not saying that I'm the only one that does it and my way is the right way, although I like to think so myself. But the way I think of it is there's subjective and objective data, right? So the subjective data is I'm going to be asking you about those lower urinary tract symptoms. All these self-evaluation of symptoms, these are different questionnaires that that you can find online, or sometimes I give to my patients in clinic. But it'll ask you, do you have a weak stream? Do you empty your bladder? Are you going to the bathroom? Or how often are you going to the bathroom? So those are all subjective things. I like to tend to back up my subjective data with objective data too. Okay. For me, what I like to do is I like to actually look at the way your stream is, and I'll ask my patients to come to the office and urinate into a toilet, and that way I can see the velocity of their stream, how much they're emptying out of their bladder, and how much they're retaining. Some people can't even, some of my patients can't even urinate, so that'll tell me, hey, they're in retention. I need to do something a little bit sooner. So that's what this urinary output testing is. And then that residual is how much you're holding on to. A rectal exam, I generally don't do a whole lot of rectal exams these days. To me, that's more for prostate cancer screening. Usually I do my rectal exams at the time of like a transrectal ultrasound. So, and then the PSA, like I was saying, also that's a blood test for a screening test for prostate cancer as well. The only objective data I generally get is if you're considering a procedure, I'll take a look, something called a cystoscopy, and that'll be a camera going through your urethra, looking at that prostate to actually visualize the blockage, to see how it's getting blocked, what the degree or severity of the blockage is. That's called cystoscopy. And then I'll also so that's me taking a look at the donut hole. And then I also take a look at the donut. I usually use something called a transrectal ultrasound, where I put a probe in your behind, and then I'll take a look at the donut to see how big it is too. And that'll give me a clue as to how big that is. And at the time, that's what I do the rectal exam. Let's say a lot of patients of mine have MRIs or CT scans. I can also use that information, and that'll take the place of a transrectal ultrasound, because that'll give me some 3D imaging that I can measure, or estimate the volume of your prostate. Okay. And then I guess I'll make one note of this. Sometimes patients have both prostatic symptoms in terms of blockage, but also they have bladder symptoms, like I was telling you. And in a complex case, there is a test, something called a urodynamics test, where that is probably the most it is the most complete test I can do to really figure out where your problems are coming from. Is it a bladder problem? Is it a prostate problem? Or is it both? So occasionally I will do that once in a while. Hold on here. All right, here we go. So we'll talk about treatment options next, okay? So treatment options, it's definitely a spectrum. So we'll be talking about, the least invasive. That just means behavioral modifications. And then first line therapies are more like your medications or minimally invasive procedures. And then finally, you have your surgical procedures, something you're going to be getting done in the operating room or with an interventional radiologist or something to help with your outlet obstruction. A lot of my patients ask me about supplements. When I take a look at the data for that, and the American Urological Association has done the same thing, they have noted that there was, it was no better than placebo. I mean, anecdotally, I'll tell you this. A lot of my patients take supplements and they tell me, they swear by them. I tell them this: if they can afford it and if they think they're getting benefit, great, keep taking it. If if they found no difference or anything like that, I'll tell them the data on it and they can decide if they want to stop that. But generally speaking, when they looked at all the the data out there, none of the supplements really made any difference. So
what is water vapor therapy?
We'll be getting to that in a little bit. And
you'll save questions till the end. Yeah.
That's why you have to be late.
But great question. Okay, we'll get there. So again, we're starting from the least invasive to the most invasive. And a lot of these are not that invasive. So keep that in mind as well. So watchful waiting, this is what I call just behavioral modifications. I talk a lot to my patients about, if they're having issues with urinating at night, like they're getting up a few times at night, I'll tell them, hey, it might be smart to maybe eat an earlier dinner, and then limiting your fluids in the evening. So that way, you're not getting up in the middle of the night to urinate. I also will tell them, limiting like alcohol or any sort of caffeinated beverages at night too, because some of those can be diuretics and make you make more urine at night. And then lastly, I often tell my patients to void twice at night before going to bed, to really empty your bladder before you go to bed. And that way, you can hopefully get a few hours of sleep. If my patients that are hesitant to do anything, this is kind of what we start off with. Obviously, your symptoms may get worse as your prostate grows. But this is a good starting spot. First line therapy, then we kind of move into the realm of medications. This is probably what I use the most of in terms of medications. They're alpha blockers. Basically what it does is it relaxes the musculature around that prostate, so it opens up the donut hole. And that way that'll help relieve that pressure and that obstruction so my patients can urinate better. Okay. The medication I personally use the most, there's a drug class, they're called alpha blockers. The one that I use is called Flomax or tamsulosin. Common side effects of that one are going to be lightheadedness, dizziness, something called retrograde ejaculation, where the ejaculate will go back into your bladder and then you urinate it out. The next type of medication these are called 5-alpha reductase inhibitors. This is like finasteride or dutasteride. These medications, what they do is they focus on shrinking the prostate. What do I want to say about this? To be very honest, I don't use a whole lot of 5-alpha reductase inhibitors in my practice. There's a potential for a lot of side effects with these medications. So I generally favor these 5-alpha reductase inhibitors in my patients who are not surgical candidates or procedural candidates, just because of the potential for side effects. What side effects are we talking about? We're talking about erectile dysfunction, decreased libido, breast enlargement, ejaculatory dysfunction. There's some research that shows that it can also mess with cognition, and decreased, or increased fatigue. So that's why I'm not a big fan of these medications unless, my patients don't want to do any sort of procedures or anything like that. In terms of this medication, one of the advantages of this medication, though, is when a prostate starts getting really large, one of the potential side effects is blood in the urine. The prostate can grow, and with it, grows all the veins of the prostate too. And this medication will actually help with blood in the urine. So I sometimes do use it for that indication. There's one other medication in here that isn't listed that the American Urologic Association does say that it can help with, and I do commonly use that too. But that one is something called tadalafil. That's the generic version of Cialis. Studies have shown that if you take that medication daily, it can help with urination too. So my patients that have both erectile dysfunction, which is common in men, and BPH, I will try to use, that's like 2 birds with 1 stone right there with tadalafil. Okay. We then are now moving towards the procedures. So some of these are office-based procedures for your prostate. Water vapor therapy. This is something called Resume. This is something that one of the procedures even that I do. Basically, what it'll be is it's injecting water vapor or steam into your prostate. That steam will kill the cells of the prostate, and over time, about 1 to 3 months, it will shrink the prostate. So it is a pretty non-invasive procedure to help shrink the prostate. Okay. For this procedure, the potential side effects, I tell my patients, your prostate for the first probably 2 weeks to 3 months is not going to be very happy as it dies off. So, and your prostate will be very swollen. So your symptoms will probably get worse before they get better. So I just tell them, you're going to have worsening frequency and urgency and burning for about 2 weeks to 3 months before things start to get better. I would say typically my patients do pretty good after about 2 weeks to 4 weeks, but it could have the potential of those side effects lingering on for 3 months. You don't need anesthesia for that one, so that's a good option for patients who can't undergo anesthesia. There's no implants inside your body, and then in 5 years, the chance of you having to have another procedure is about 4.4%, so pretty low. And that's why I use this in my arsenal of procedures that I use or surgeries that I do. The next one is something called a prostatic urethral lift. This is more commonly known as Urolift. Urolift is basically, think of your prostate like the curtains on a window. I would be putting 2 metallic clips or staples towards your prostate, and having the blinds or the shades of that window kind of be tacked up to the side. Okay. And that would help relieve the obstruction that way. This is also another procedure that can be done in the office. The only difference is that because of those metallic clips, there will be an implant inside your body. Possible side effects, again, are going to be blood in the urine. You'll see a theme here. Blood in the urine, frequency and urgency, pain down below, and painful ejaculation. Those are all possible. Retreatment rates are a little bit higher, about 13.6% in 5 years. For me, I'm going to be very honest with you guys and say, hey, I'm a little bit biased in my practice. I have to remove a lot of these after they're placed with other urologists in town. So I don't do this procedure just because I see a lot of retreatment rates, and if it fails, that means I have to also potentially remove those clips that are placed in there. The advantages of these 2 that I just mentioned is if if ejaculation is important to my patients, these are one of 2 modalities or procedures that are approved to help preserve that. A lot of the other procedures I'm going to talk about after this, they do not preserve ejaculation. And then I want to be clear too, that does not mean erections, that means ejaculation, the fluid that comes out after an orgasm. All right, next up we have photoselective vaporization. So now we're kind of moving into the procedures that you have to probably undergo anesthesia, okay? So this is something called green light therapy. I think that's the more common name for it. But basically, you use a green light laser to vaporize the prostatic tissue. You have to undergo anesthesia for this one as well. There's no implants inside your body. And think of this like a roto-rooter using a laser. For this one, again, blood in the urine, frequency urinating, incontinence. You can have scarring of your bladder neck, or bladder neck contracture is what they're called. And then this can start affecting your ejaculation as well. This one, I personally don't do this procedure, but it is one of the procedures that is approved for patients that are like on blood thinners due to the decreased amount of bleeding with this procedure. So if you're on, you have cardiac issues and your surgeon is worried about bleeding after surgery, this is one of the procedures that is approved by the American Urologic Association. A transurethral resection of the prostate. This is what the gold standard has been for over 50 years. This is this is truly a roto-rooter. It's basically you'd be asleep under anesthesia. It's transurethral, so there's no cuts on your body or anything like that. You go in there with a scope in your prostate and then just make that donut hole larger by physically removing prostatic tissue. Needs general anesthesia. Retreatment rate, 5.8%. I somewhat think that it depends on who's doing your TURP. Some people are more some surgeons are more conservative than others. Kind of just depends on, what your surgeon kind of tells you there. Again, same things, the similar side effects, blood in the urine, leakage after urination, retrograde ejaculation. You can have scar tissue that builds up after surgery as well. This one, I do this procedure. It's been around for 50 plus years. I think it's because it works. So that's why I keep it in my arsenal. A prostatectomy. So this is kind of a, how do I say? We're using the term prostatectomy pretty loosely here, in my opinion. I would say about 20 to 50 years ago, patients would sometimes get something called an open prostatectomy for lower urinary tract symptoms, where they have to make an incision over your belly, and then a urologist would literally, with their finger, scoop out all that prostatic tissue and remove it that way. Obviously, that was a very bloody procedure. Patients would have to stay in the hospital. The way that people do it now, if they're going to do a prostatectomy of any sort, is they're going to do it robotically, probably stay in the hospital for overnight or something like that. I personally don't do that. I don't know if there's anyone in town that probably does these robotic. It's called a simple prostatectomy, where they're just removing just the blockage part of your prostate. But some patients or some people are still doing that. Obviously, the risks include bleeding, scarring again. I mean, that's with any sort of surgery. And then, if they're doing it robotically or open, that's a cut on your body there. So risk injury in the bowels or something like that. The good thing is it works, 2.7% retreatment rate. Let me see here. There's a few on here that I will mention. I guess I'll mention them at the very end. But those are like the ones that I just mentioned are probably the more common ones, traditionally speaking. The next slides are a little bit newer. Okay, so there's this newer procedure called iTind, or temporarily implanted nitinol device. So what this is an implanted device in your prostate, and it stays there for about 5 to 7 days, and then the implant is removed. The idea of this is that pressure that it's almost like a stent inside your prostate, okay? And they eventually remove the stent. But for that 5 to 7 days, it's going to cause a lot of pressure on your prostate. And with that pressure, it'll it'll not only physically make an opening, but it'll also kill the prostate cells around there to keep it open, so that way it stays open. One of my partners does this. I mean, I think for these devices, they are approved by the American Urologic Association. They used to just be experimental. The selection criteria, not everyone can get this or is eligible to get this though. So it's very important that you talk to your urologist. Your prostate has to be a certain configuration and a certain size. So it's not like anyone can just get this. But this is an office-based procedure. It's a temporary implant. The data is, there's only 3 years of data because it's relatively new, and retreatment rates are about 8.6%. So, side effects, obviously, again, blood in the urine, pain, the fact that there's something inside your prostate will be a little bit uncomfortable for about 5 to 7 days. Okay. Next up is aqua ablation. I think there's a few urologists on the northwest side of town that are starting to do this. There's a few up in Phoenix as well. But this is using a robotic technology and a fluid jet system to remove prostatic tissue. What are my thoughts on it? Let me describe this to you guys first, okay? So I don't do this procedure either. I've seen a few videos of it. Basically what they're doing is they're with an there's going to be a scope inside where the prostate is, and it's basically going to just use high pressure water to ablate the tissue. Okay, and they're monitoring, or they're looking at how much they're taking away by an ultrasound in the rectum at the same time. So obviously you'll be asleep during this, but this is also again, it's relatively new. You need to have a certain prostate configuration and size for this to happen. This is allegedly one of the procedures that also helps preserve ejaculatory function as well. I think the big side effects for this one, from what I've been reading upon and when I do my research on this, is just blood in the urine, because they're using that robotic technology to look at where to ablate, but the thing is it's not stopping the blood either. So generally speaking, after your surgeon's done, he has to go back in there and then stop all the bleeding. So that's probably one of the bigger side effects there. And then frequency and urgency, as well as injury to the urethra or the rectum is also possible. Again, for this modality, it's about, it's relatively new, so about 6% retreatment rate. This one, I don't even know if I want to mention, to be quite honest. This is like an older technology, transurethral needle ablation, or something called TUNA. It just didn't work that well. I mean, you can look at the retreatment rate there. It's not a good procedure. So I don't know if there's anyone doing that these days. They're trying to reinvent the wheel, though. I'll say that. Different companies are looking at trying to do something like TUNA to try to make it work, but I just don't think it's right. I don't think it's worth mentioning, really. There's 2 procedures out there that are not on here that I think are, promising, and one of them, like I said, I'm gonna be very honest with you guys. I'm very biased. It's probably what I do the most of. One of them on here is something called holmium laser enucleation of the prostate. It is a minimally invasive way to do a prostatectomy, where it's transurethral. It's a different technique compared to like a TURP. But basically, instead of working from the inside out, I'm working from the outside in. So I'm really enucleating a lot of your prostatic tissue. The big side effects, so that one requires general anesthesia. Sometimes if you live far away, like from some of my patients are from like Sierra Vista or Safford, I usually have them stay overnight just in case. Side effects for those are going to be leakage and retrograde ejaculation. It is it is probably the only procedure here other than TURP that is size independent, meaning that I can do it for almost any prostate. I have my own personal criteria, but the American Urologic Association said that's probably the only procedure out there that is size independent. So for me, my practice patterns, I get a lot of really large prostates. ranging from 2 times the size of a normal prostate to 10 times the size of a normal prostate for that procedure. And then if you're on blood thinners, that's the only other procedure that is approved for patients who are on blood thinners or anything like that. It's called holmium laser enucleation of the prostate, or HOLEP. HOLEP. And then the other one on here is, the other one is something called a prostatic artery embolization. That is not a urologic procedure, but it's something your urologist could recommend. It is an interventional radiology procedure. The idea being that your interventional radiologist would embolize the arteries that go to the prostate. And by killing off the blood supply to the prostate, it can shrink the prostate there. It started out in Europe. The Europeans have been doing it for a long time now, maybe 5, maybe 10 years now. The American Urologic Association finally approved that, and then they're very vague in their statement about it, though. They don't talk about a size, they just say it is an option. So for my patients that have really big prostates that may tend to bleed, I sometimes do tend to do that first, and then I do something else on top of that. But that, it's not instant. It takes time because the prostate has to shrink. So those are the 2 other, I would say, more common procedures that weren't listed on here. Obviously, everyone has different insurance, so you got to just figure out if your insurance covers these procedures that your urologist is talking to you about. And in summary, we talked about the prostate. The prostate, I guess one thing I didn't mention is what is the function of the prostate? It just provides ejaculatory volume, and it also converts a specific type of testosterone, converts testosterone into a more potent version of testosterone. We talked about BPH, how it's not cancer, and it's just your prostate growing naturally, generally speaking, with time. We talked about options in terms of just behavioral modifications, first-line therapies, including medications, and then we started slowly going into the spectrum of procedures, office-based procedures versus something under anesthesia, physically removing tissue versus somehow shrinking the prostate by decreasing its blood supply. If these things apply to you, maybe wise to talk to your primary care doctor or your urologist. Again, thank you for having me here. We can take some questions now if you'd like.
So thanks so much, Dr. Lwin. I do have a couple of questions. One is, what are some of the earliest signs that it's maybe time to talk to your doctor about your prostate?
Okay, great question. So early signs, like I was saying, when I worked some of my patients up, I talked to them about subjective and objective data for me, right? So the subjective things, I think the most common things are going to be like weak stream. I feel like I'm always going to the bathroom. I'm getting up at night a lot. What else do my guys tell me? I feel like I don't empty my bladder. I'll finish urinating, and then 5 to 10 minutes later, I have to go back or something like that. Those are, or their spouses are telling me, hey, he spends a lot of time in the bathroom. And so those are some early subjective signs. When I check you out in the, at the office, what I'll be doing is I'll probably be asking you to urinate into a toilet so I can see, how weak is your stream? Are you holding on to a lot of urine? Like I have some guys sometimes that come to me with over a liter of urine in their bladder after they urinate. And to me, I'm like, all right, you need to do something yesterday. So, in my practice, I see a spectrum of patients in terms of where they're at in their symptom, how their symptoms are manifesting. But the early signs are going to be like those, weak stream, you don't feel like you empty your bladder. And then, and the objective ones, I guess, are going to be ones of like, I can barely even, I have to sit down to urinate, or I have to, my stream is just really weak and I can barely even make it into the toilet these days.
Great, okay. Now, what factors do you consider when determining which procedure to go with for a patient? Like, how, I mean, you have an awful lot of choices, more than I think in a lot of different areas, right? For the prostate, there's quite a few options. So how do you choose?
So in my practice, what I choose is I do a lot of shared decision making, to be quite honest. I try to figure out what is important to my patient, but also, what is his prostate like? So for me, like I was saying, a lot of the determination comes down to a cystoscopy. That's me taking a look inside the prostate and examining determining the severity of your obstruction. And then I also take a look at the size of the prostate too. I did make a statement earlier about how the size of your prostate doesn't always correlate with your symptoms. So I have some patients that have normal sized prostates, but they have a really bad blockage because they're instead of a straight line of their urethra being straight, it's kinked or something. So I need to deal. Thank you. I'll have to deal with that kink instead. And so and then going back to what I was saying earlier with the shared decision making is if ejaculatory function is important to them, I'll take that into consideration, and I'll tell them, hey, your options may be limited because there's only a few procedures that preserve ejaculation.
Okay.
I hope that answers the question.
Yeah, no, it does. Now, what about if someone is going in, is having the treatment, based on the different types of treatments that you tend to do, what's the recovery time? And I know you mentioned, like, for one, that you may have them stay overnight if they were coming maybe from southern Arizona or out of town. But what's the recovery time on most of these?
So it depends on the procedure. And then going back to your other question, I guess the other thing is I have to keep in mind that I'm just one urologist here in town. So I would say most of the urologists that I know in town, and just I guess abroad, they generally do at least 1 to 2. Personally, I specialize in this, so I do 3 different versions of these procedures. So it kind of just depends on what you want. But going back to your other question of what the recovery time is like, I would say for the office procedures where you don't undergo anesthesia, that's an in and out procedure, probably takes under 20 to 30 minutes. The resume procedure, for example, that takes about 5 minutes. The Urolift probably takes 5 to 10. I haven't done one of those in a very long time, but that's kind of what I remember it being like. I don't know about that new one called the Aye Lwin. And then the thing is the trade-off though is that if you do less up front, you probably have to have a catheter for a little bit longer. So for example, my resume patients, they have a catheter for about 4 days. Whereas if I do more, I'm cutting your prostate or something like that, you have a catheter for 1 day. The procedures where I'm, physically removing the prostate blockage, that being a HOLA, a TERP, green light or whatever. Usually those, generally speaking, those are outpatient procedures, and you get the catheter out probably within 3 days, depending on your urologist, whatever they prefer. Okay. An open simple prostatectomy or a robotic one, probably 1 night in the hospital at least.
1 night, okay, all right. So you're anywhere from either an outpatient anywhere from maybe outpatient, an outpatient to maybe a night in the hospital. Yeah,
generally speaking, these days, a lot of the prostatic surgeries are, they're becoming what we're considering all minimally invasive. And so you stay in the hospital at most for a day, generally speaking. Okay. And then in terms of, recovery though, that's where, you'll have a much bigger variation, because if you imagine, the prostate has been growing over 30, 40, 50 years, right? And so a lot of my patients have gotten used to urinating one way, but I'm changing that overnight. So it may take anywhere from 2 weeks to a few months to learn how to pee again, like when you were 18. So that's what the recovery is like. And some of those procedures, like I was telling you, the prostate may be swollen, So, procedure, I would say generally though about 3 months, 2 to 3 months or 1 to 3 months is probably a very general way for most of those procedures if I had to pick a time frame.
Okay. Now, where is your office? Why don't you share that with me? I do have the phone number here as well, but if you could sort of share where you're located when somebody.
I'm on Tanca Verde. Let me see if I can pull up. I think one of the first slides had the address. I'll be very honest, I don't even know what the address of my office is. Let's see here. My office.
6325.
Yes, that's right. Thank you. 6325. I think it's East Tanca Verde. So, yeah, if you want to make an appointment with me, I'll have to apologize in advance. I'm probably already pretty booked up, but I can always just try to.
Okay, and the phone number is 520-795-5830. So you can always give a call. You are with Arizona Urology Specialists. If you're looking, usually it's on Tanca Verde, just Tanca Verde and Pima, basically.
Yeah, that's pretty accurate.
That's about as close as I can get on there. So.
There you go. So, I think we have some questions here in the audience.
Yes, so what I'm going to do, I'm going to wrap up with our online audience. I'm going to turn it over to you to answer any questions in person, and I just want to thank you so much for being here, Dr. Lwin.
Again, the pleasure is mine, and thanks for inviting me, and I'll probably be here next year.
Thank you. All right. Thanks again for being here. We look forward to seeing you again. We will be doing the nuts and bolts of the men's pelvic floor, and that is tomorrow, Wednesday, October 2nd at 2 p.m. with Samantha Johnson. She is a pelvic floor therapist, DPT with TMC outpatient therapy. So if you are interested in that class, please give us a call in the office. We'd be happy to get you registered. We also have some spots that are also available here if you want to come in person. The phone number is 520-324-1960. I also want to let you know about one other talk that is coming up this week. We have Knee Deep, Exploring Joint Reconstruction, on Thursday, October 3rd at 4 p.m. with Dr. Chad Hills with Tucson Orthopedic Institute. Again, please give us a call at 520-324-1960 if you are interested in that class. We will look forward to seeing you soon. Thank you.